Good day, everyone. Uh, Thank you so much for those of you who are joining me live and for those of you who will watch this later. We've had a nice long break, and I just wanted to ease us into our new year of learning, where hopefully we'll go through more ABGs, ECGs, medical emergencies, medical management in the emergency department of different uh, cases and things like that. And today is just a basic one on lactic acidosis, which is something we do see in the emergency department, although it's not your first diagnosis normally. In other words, it's not a clinical diagnosis. It's a diagnosis normally made once you've got your blood gas. So let's have a look and see what it is. So sorry, I just want to hide this. Yeah, okay, so that you can just see what's going on. So let's take a patient scenario of a 30-year-old male patient who presents to the emergency department with confusion and abdominal pain. He reports recent initiation of anti-TB therapy. And on the history, he's got pulmonary TB, type 2 diabetes, medications, he's on rifampicin, isoniazid, ethambutol, metformin, no smoking or alcohol. On his vitals, you see his BPs are a bit low, heart rate a little bit high, respiratory rate high. His SATs are okay on room air, and his temperature is a bit high. And his general appearance is that of diaphoresis and tachypnea. So even though we know we're going to be dealing with a lactic acidosis, if you were to see this patient initially, there would be a few things that you would think of, especially with confusion and abdominal pain and recent TB therapy. You'd start thinking about DILI. Drug-induced liver injury is very common amongst patients who have recently been started on TB therapy. There's always a possibility that the liver starts to fail. And then as the liver starts to fail, we notice that the ammonia levels within the body start to pick up. And when the ammonia levels pick up, this can often lead to confusion. Abdominal pain is also one of those things that, is very non-specific. So what we've got here is a patient with a non-specific set of symptoms. And, he could be tachypnic due to the TB. He could be diaphoretic due to fever. We see he's a bit pyrexial over there. For all of you who are joined just now, it's not to worry. And listen, at any point, if anybody wants to stop me and ask questions, that's perfectly fine. It's not a problem. So, like I was saying, these are the things that you need to think of when you initially see this patient. Now, always remember, abdominal pain, especially if it's epigastric, can also be due to cardiac complications. So it's always a good idea in patients who have low BPs, high heart rates, epigastric pain, the, especially patients who are acutely ill, just to do an ECG for them, there's no harm in it. Now, in this particular case, like I say, we're looking at lactic acidosis. We know the diagnosis even before we start, but this is just how your mind should think about what are the possible differentials going into it. Okay. Now, there are a few other differentials that we'll get into a bit later. There are some things that I want to teach you about in terms of lactic acidosis, but you've got a patient who's a type 2 diabetic with confusion and abdominal pain. This could be a DKA as well. It's very possible. So there's a lot of things that it could be. So it's difficult sometimes when you have a patient who has non-specific symptoms, multiple comorbidities, and then who comes into your emergency department. So remember, your job in the emergency department, we call it the ED, not the FD, not the final diagnosis department. You're not meant to make a final diagnosis in the emergency department. Your job is to stabilize and at least get a working differential. So in your mind, these are the differentials that you'd start thinking about. And then you start doing your investigations. So your basic bloods, you would get a blood gas, you would get an ECG, you would get a chest X-ray. If you were suspecting liver failure, like I said, DILI is very, always a possibility with TB treatment. You would get LFTs. And these are the things that you would look at. Okay. So that's where our patient stands at the moment. So let's say now, okay, you've done your ECG, it looks fine. You've done your chest X-ray, it looks okay. Everything else seems to be all right. Even your liver enzymes seem all right. It's only when you get your blood gas back that you start seeing that there's a bit of a problem. So what we have here is that we have a pH of 7.22. All right. So that's indicating an acidosis. All right. So whenever we're looking at a blood gas, then the first thing that we look at is your carbon dioxide. All right. Your partial pressure of CO2. So if it's raised, then we know that there's a respiratory component to it. And if it's not, then there's most likely a metabolic component. Now, in this case, the PaCO2 was 4.5, which is well within normal. So he's not having any sort of respiratory failure that's leading to the acidosis. However, the bicarb we can see is low. 12 is relatively low, and it indicates that this could be a metabolic acidosis that's causing this. But the other thing that we notice is that the lactate is quite high. So a lactate of 8 is very well, I mean, it's not ridiculously high, but it is quite high. Now, often I found amongst our younger doctors, they sort of not dismiss lactate, but they're often quite unsure about what to do when they see high lactate levels. So I'm going to take a minute here just to explain what lactate is. So lactate is essentially your cells screaming in agony. And when they scream in agony, they don't say, ah, lactate comes out, right? Instead of saying, ah, lactate comes out, all right? So that's how you've got to think of it. You know, your cells are in agony. So this lactate that comes out, where would it first come out is normally in the microcirculation. So in the distal limbs, your fingers, your toes, your smaller vessels throughout the body. The reason being that these are normally the ones that are more susceptible to poor circulation, poor delivery of oxygen, things like that. And that forces the body to go into anaerobic respiration. All right. Now, if any of you can remember the Krebs cycle, that's very good. I remember learning the Krebs cycle purely for my exams, and I completely forgot it after that. I bring it up once in a while, but I can't remember it for the life of me. So if you can remember it, that's very good. I'm happy for you, but I can't remember it. I just remember there's aerobic, anaerobic, and that was about it. Okay. But lactate comes from anaerobic circulation. So what this tells us is that even though there's a metabolic component to this, and we've got a discussion on metabolic acidosis in the in all the tutorials. You can go back and have a look. But what's more concerning is the lactate. The question is, why is this lactate high? Because this is not a respiratory problem. So that means it's either circulatory or one of the other differentials, which we'll get into now. Okay. All right. I hope that makes sense. I hope it does. So let's look at common causes of lactic acidosis in the emergency department. Now, remember what I said, you can't get final diagnosis, but you can start looking at things. So the first thing is tissue hypoperfusion and hypoxia. So sepsis, it's a possibility in this patient because the temperature was a bit high. He's a type 2 diabetic. Of course, any type of shock where you've got now your decreased BP, so there's decreased ability, there's decreased blood flow into the microcirculation, and cardiac arrest, of course, will immediately give you quite high lactates. All right. Just as a separate point, in trauma, if you have a patient with, for example, a stab to the chest, and you suspect that they may have a stab heart, and blood gas at that point with high lactates almost always indicates a stab to the heart. All right. So what's the other ones? Now, one of the other ones that we do get is metformin-associated lactic acidosis, which is quite common in patients with renal impairment. So we do get these patients who are on metformin for a long time. They've been seen at the clinics. No UNE is done, or UNE is done like once every 2 years, or whenever the person at the clinic can remember, or they see one doctor at OPD, then they see another doctor. And everybody is forgetting to check whether the metformin is affecting their UNEs. And eventually they end up in renal impairment and they continue on their metformin. And eventually they can get metformin-associated lactic acidosis. Now, I've been doing this now for about 20 years. I've only seen it twice. So it's not to say if patients come in with lactic acidosis, you immediately scream metformin associate, but at least it's something to keep in your mind should the patient have be on metformin and have lactic acidosis. Now, this is one of the more common ones that I've seen, which is isoniazid overdose. Now, isoniazid in our setting, especially in South Africa, is handed out like candy at all the TB clinics, all right? Because it's prophylaxis. That's what you are treating a patient for. The problem with isoniazid is that isoniazid is lethal in very small doses. So even 3 to 4 tablets of isoniazid can put a patient into severe lactic acidosis. And of course, patients who do want to, end their lives, they generally won't take 4 tablets. They'll take a whole bottle, or, they'll take quite a few. Let's put it that way. The only thing with isoniazid overdose, and one thing to remember, is that they tend to have seizures, uncontrollable seizures, combined with lactic acidosis and a history of being on TB prophylaxis. All right. So my apologies for that. He's trying to call me. Sorry about that. It shouldn't disturb you anymore. And yeah, so that's the thing with isoniazid. Okay, so let's look at another set. So severe infections, as we said, so secondary to TB or pneumonia. So if you've got a bacterial infection over and above your TB, this can definitely lead to this. Severe liver dysfunction, as we had said, any patient on TB treatment, there's always a possibility of delay, and then they can have impaired lactate clearance. It can cause a problem. Intoxicants such as ethylene and methanol, although these are not as common when causing it. Now, one of the other things that I've noticed in practice over the years, lactic acidosis is also very commonly associated with malignancy, undiagnosed neoplasms. These patients often come in, especially in our setting, unfortunately. For those of us working in the public sector, we know that a lot of our patients present late. And unfortunately, by the time they come, they may have underlying CAs that are already quite advanced. The CA itself is causing hypoperfusion, it's causing hypoxia in certain areas. It in itself is a hypoxic area, if you can look at it that way. And it is also releasing lactate. Neoplastic cells tend to release lactate quite often. So should the other possibilities not seem likely, there's always a possibility that it may be an underlying malignancy. But it's not a diagnosis that you can come to as a final diagnosis in the emergency department, but these are just things to keep in the back of your mind. So what do you do now? Now you're in the emergency department. You've determined this patient has a lactic metabolic acidosis. How do you manage them? So the first thing, of course, is you try and treat the underlying cause. So does the patient have sepsis, hypoxia? Did they overdose on isoniazid? Did they overdose, take too much of metformin? Do they have renal impairment? Now, those, of course, will come from your investigations. Is it a cardiac problem? Whatever it is, that's where you initially try and treat. So sepsis is quite easy. You start with antibiotics, you start with steroids should be indicated, things like that. And then you make sure that you get enough oxygen into the tissues. So your patient's SATs need to be kept relatively high. And you can do that either through high flow oxygen or intubation if needed. And IV fluids, of course, you want to pick up your BPs. You want to have a map of a minimum of 60. Now, of course, it depends on what your systolic and diastolics are, but you are trying to get your maps up for 2 reasons. Number one, the increased blood pressure will encourage blood to flow through those hyperperfused areas. And number two, it will increase the clearance of lactate through the kidneys so that you start to eliminate that lactate. Now, like I say, lactate lives in the microcirculation. And when we take blood, we take blood from the macrocirculation. So what I've had in the past is that shame. Some of my younger doctors, they, for instance, let's say get a lactate of 8, and they start all of these interventions. And when they do their second blood gas, now all of a sudden the lactate is 10, and they feel like they're losing. The truth is that you're not losing. All that you're doing is that you're flushing the lactate out of the microcirculation into the macrocirculation, and that's why it's picking up as higher. So you often find this situation where it starts off low, goes a bit high, and then drops again. But once it starts dropping, you know you're going in the right direction. Okay. So I hope that makes sense. And of course, you correct your metabolic acidosis as well. So generally, what we do with use of sodium bicarbonate, just remember the rule of sevens. So if your pH is less than 7, in this case, even at 7.1 in this particular case, but if your pH is less than 7 or your potassium is greater than 7, it's always a good idea to start sodium bicarbonate. Well, in the case of the pH, of course, to pick it up, and in the case of the potassium, to drop the potassium, which sodium bicarb does. So, the way that you give it is that you give 1 milliequal per kilo, and 8.5% soda bic is basically 1 milliequal per milliliter. So most of us have 8.5% soda bic available in our emergency departments. So if you have a 50 kilogram person, you would give them 50 mils. If you have an 80 kilogram person, 80 mils, and so on and so forth. Should you only have 4%, then you, of course, double that. The most important thing with sodium bicarb, don't rush it into the system. You're not going to improve the patient's chances by suddenly increasing their pH or suddenly decreasing their potassiums. You need to give it over at least half an hour minimum, and even over an hour is fine. But remember, every time that you give a transfusion of sodium bicarbonate, check your blood gas after that to make sure that things are improving or not. And of course, you need to monitor your renal output. So I hope that makes sense to everyone. Okay. If there's any questions, listen, even you're more than welcome to ask me on the chat as well. And if you're feeling shy, it's no problem. You can always ask me later on the groups or whatever it may be. You can even just WhatsApp me. Privately, it's no problem. So let's just have a look at these two, which is MALA, which is metformin-associated lactic acidosis, and isoniazid overdose. The reason why I bring these two up is that if you are faced with them, they can sometimes make you, it's something that can cause you to panic, especially if you've never seen it. Now, like I say, MALA is not as common. It does occur, but very infrequently, as compared to isoniazid overdose, which I've seen many times in the emergency department. But it leads to, MALA leads to nausea and vomiting, abdominal pain, hyperventilation, which can mimic Kussmaul's bleeding or breathing, or it looks like Kussmaul's breathing. So of course, you're going to discontinue the metformin, but the problem is the metformin is already in the system. You're going to correct the acidosis as far as possible. But all of these patients need ICU. Your job in the emergency department is to stabilize them as much as possible. And then once they get to ICU, then that's where it's determined how they're going to get rid of the metformin. So most patients will undergo hemodialysis. Some of them will undergo lipid therapy, chelation, things like that. But that's not your concern. That is the concern of the physicians once the patient is in there. If you are doing an ICU rotation at some point and you do come across a case like this, remember, a hemodialysis is probably your best bet to actually get rid of the metformin. And then, of course, a lipid chelation can also be used. So lipid chelation is quite easy. We merely use our, um, what do you call this? The feeding bags. It's on the tip of my tongue. It's just slipped. Parenteral nutrition, sorry. So that has very high lipids, and we ask for a higher lipid one like that. And the lipid tends to bind the metformin and get it out of the system as well. Now, isoniazid is very, very scary when you do see it because these seizures don't respond to anything. You can give as much dormicum, benzos, you can give whatever you want. They somehow still keep on having seizures. Of course, they have an altered mental status. My apologies that it's cut off over there. So the thing with isoniazid, the best way to treat it is to give the patient pyridoxine, which is vitamin B6. Now, in the majority of the cases, we won't know exactly how much the patient has taken. So we often give the maximum, which is 5 grams. Now, it's not an easy thing to give. The reason being that it doesn't come in an IV solution. It comes as tablets. So somebody's got to sit and crush all those tablets, mix it with the liquid, and then pass it through the nasogastric tube. If you do know the exact amount that was given, that's even easier because then you can match tablet for tablet. which will approximately work out to 70 milligrams per kilogram. Sorry, I put IV here because in some areas you do have vitamin B6 available IV, but I know in most of our public hospitals in South Africa, we only have the tablets available for vitamin B6. So, you can give tablet for tablet, or you can give a maximum of 5 grams, and it's crushed and passed through a nasogastric tube, and it tends to counteract your isoniazid quite quickly. And thereafter, once you start doing seizure management, it tends to go a lot better. And you continue your pyridoxine until the seizures are resolved. Now, I must be honest, in all the cases that I've treated, once we've given them the pyridoxine and we've put them on anticonvulsants, they tend to settle down quite quickly. They most of the time end up being intubated, they end up in ICU, and they end up being treated there. And of course, the problem with intubation and paralysis is that the patient may still be seizing. We just can't see it. So very often the patients will need an EEG to see if they are still seizing or not. But it depends if it's available to you or not. Okay. So that's just the end of the presentation, just a little joke to finish off. And it is true, they say you have to be a little bit crazy to work in the emergency department, and I agree with that completely. So I hope everybody learned something, and I hope everybody will, re-look at the video at some point. It was a nice, easy case just to ease into the year. And hopefully on Wednesday, we'll have another case, maybe an ECG, or we'll look at another clinical case or whatever it is. But thank you so much to all those who joined live. Yeah, I know there may not be too many questions, but if they are, you're more than welcome to message me, or even on the YouTube comments, or those of you who are on the group, you can message on there. And I hope that you learned something today. And yeah, we're going to end it there, and we're going to post it now on YouTube. But thank you so much for all those who attended. I really appreciate it. And I hope you have a great day. Okay, keep well. Bye.